So I'd like to thank Hanita for this invitation. I'd like to show you why I perform in my clinical practice, the defocus curve, and what you're missing out if you're not doing it. I'm Renato Fernandes from Brazil. I'm a cataract surgeon. I have over 100 lenses, intensity lenses implanted in the last 2 years maybe. And first, what is a defocus curve? Professor showed us the focus curve is a graphical representation of the visual acuity in this range of distances, and we measure it like this. I put together the patients with the same IOL. I make them, we conduct some satisfaction questionnaire so my staff can be aware of how good the lens is. And then I measure the visual acuity without correction for distance and for near. And I perform the best corrected vision so I can put in this chart right here. So it's in Portuguese, but if you want, I can email how I make it. And this goes in the patient's name, the IOL implanted, the auto refraction, the visual acuity without correction for far and near, the refraction the patient accepts, and the visual acuity with the best refraction goes here in the 0. And then we add +1 diopter, and we measure the visual acuity, and we put in this box here, and we keep on retracting -0.5 of a diopter, and we put the visual acuity here, and we go filling these visual acuity boxes until we reach -3 or -3.5. And this is how it looks like. This is my assistant curves, just for a comparison. My assistant, she's 21 years old, and she's a pretty light myope with -0.5. She has 20/20 visual acuity without correction, but corrected, she's 20/20. And you can see she has a pretty steady accommodation, and it falls only after -2.5. My curve, I'm 49 years old. I'm a mild myope, I'm -3.5, and this is not looking good for me, but this is nature. You know, I have a very good corrected vision so far, and I have no accommodation whatsoever after -0.5. So then we collect the visual acuity for the patients. I'll show you some examples. This is the patient. It has an intensity. This is the auto refraction. There's some cylinder left. The refraction she accepts is -0.5, and it goes like this. It's 20/20. She's already 20/20 J1 without correction, and when we add +1 and we go measure, subtracting -0.5, it goes like this. It's very interesting because this IOL, it is refractive for the intermediate vision. It's not unusual for the patients when you're doing the test and you're taking out the power, they refer this -2 as the best vision in the test so far. The patients go, oh, no, now it's very good because it's refraction at this point. So another case, this one is not a very good case. You see, there's a 20/25 J1 because the patient has a lot of astigmatism left, but it's a happy patient, so I will not mess with it. But it will take -0.5, and with -0.5, she's 20/20. And then +1, 20/25, and then 20/20, everything. And you can see again, it goes down a bit, but again, in -2, it's already 20/20, and this is the spot where the patients, because the IOL is refractive in this point, they will refer the best vision. This is another IOL from another company. I do this for every IOL I implant. And what do I gain by doing the curve in my clinical practice? I can evaluate the visual performance at different focal distances, and I get to compare the IOLs to see how they perform in my clinic, in my practice. And it helps me a lot to adjust my surgical planning, and I'll show you why. I learned after all these curves that intensity best performs with a plus target. I think it is because of this intensifier right here in -1. It is very forgiving with plus targets. And now I set my target, my personal target, to the closest, to the positive, closest to but not exceeding +0.5. I think these are the patients who perform the best, especially for distance vision. And I think it is because of this. It makes very good when it's -1, or in this range here, which would be like the plus half of a diopter, it has a very good performance. So I am safer in the positive side of the refraction target. And I get to evaluate intensity against all other lenses. It's very important for me, like this. And also, this is the way I always had a hard time, because I'm not a scientist, I'm a surgeon. I always had a hard time plotting this graph, you know? And then I use LLMs to make this long prompt, so I can just take pictures of those charts, and the LLM gives me the graph right away. It's easier now. And this is how I do my surgical planning. This is a questionnaire that I built myself. It says zone 1, like very close, shorter than 40 centimeters. Zone 2, from 42 to 55 centimeters. Zone 3, 55 to 90 centimeters. And far away, which is over 2 meters. There's a lot of activities the patient has here. I'm not interested in the particular activity, although sometimes it's important. I just want to see how many boxes are checked in each one. And I also ask, how meticulous is the patient? How hard he wants spectral independence? And what is the investment? Because in Brazil, you have to charge the patient out of his pocket. How is the investment he's willing to make? This helps me decide what's the best IOL for the patient, if he has a good eye for this. And by engaging my team in doing this defocus curve, my team gets to know the patient satisfaction and the quality of the lens, and they are more prone to engage with IOL indication, because it's very expensive in Brazil. So all the team has to believe in the lens quality, in the IOL quality. And what I think is lost by those surgeons who do not perform the curve, they lose the understanding of the lens performance, because one thing is the ideal IOL performance for the ideal patient in scientific study. The other thing is how it really works in our clinics. You fail to identify the limitations of each lens. You fail to optimize your surgical planning, because every surgeon should optimize his results for his biometry. And it's very important. Do you remember when I show my assistant's curve and my curve? When I show for an unhappy patient his defocus curve, and I show my assistant's 21 years old, and the patient who is 70, 75, sees that his curve is much more similar to my 21 years old assistant than to my falling presbyope curve, it makes the patient less unhappy with the results. So she can compare, she has a graphic and a hard data to compare, and see that she has no reason to be unhappy with the result. So when I give the patient, an unhappy patient, the opportunity to compare the curves, she will be happy with me. So that's it. This is a video. It's in Portuguese, unfortunately, but it's a fellow surgeon that I operated with, Hanita. And this 110% is when it's what he's very happy with the second lens implantation. And it's something that I show my patients when I want to make them understand how the lens works better with the two eyes implanted. Okay, that's it. Thank you. Thank you very much for the opportunity.